business. Good morning, everybody. This is a scientific session based around elbow surgery. So Dermot Maloney is my name, and with me is Stefan Greiner. So we're very happy to welcome Joachim Sanchez-Sotelo, who's going to speak to us about the S.O.S, a supracondylar osteectomy and shortening procedure for non-unions of the distal humerus.
Thank you very much. Good morning. Congratulations to Dr. Calvo and Ruth Delaney for a fantastic meeting. And thank you for allowing us to present our research on ORIF for distal humerus non-unions. We know that when we face a patient with a non-united distal humerus, there is a number of features that can make the surgery difficult, including bone loss, the presence typically of a joint contracture, retained hardware plates and screws, ulnar neuropathy, sometimes also secondary degeneration of the cartilage, and then if you had prior surgery, or maybe infection, that can make surgery complicated. And as such, when we operate again on a patient with a prior non-united distal humerus, if you choose internal fixation, it is somewhat unpredictable, especially for the very low or intra-articular non-unions. If you choose an elbow arthroplasty early on, the outcomes are very good, but at long term, there are some failures secondary to mechanical failure or infection. So in our institution, we developed the so-called S.O.S procedure, which basically means that when you have a patient with a non-union, most of the times there is bone missing at the supracondylar level. And one way to manage that is to intentionally shorten the humerus, because the goal is to achieve compression by using parallel plating, and oftentimes that requires also adding bone graft, both for biologic reasons and also as an augmentation. So this is an example of a patient where you could see how you try to fit the segments. They don't really fit properly. One strategy is to shorten the humerus. Now, if you do that, the olecranon fossa and the fossa for the radius and the coronoid are going to disappear. So you have to move the distal segment anteriorly so that there is a space in the front for the radial head and the coronoid to articulate. Then you use your preferred fixation method. We like parallel plating with compression, and typically we use a clamp that is supported by a K-wire distally and a screw proximally. Maintain that compression with a compression screw, then switch the clamp to the opposite side and do the same thing. And now you have contact and compression, but you also want to augment your fixation with bone graft. And one thing we have moved to do in our cases is to create little plates of bone that sometimes can be structural, so they can give you support on the column. And also, if they are just providing biologic enhancement, they will stay there because of the screw fixation. But you have to recreate the olecranon fossa afterwards. So these are two essential steps of the technique. You shorten the humerus, apply bone graft, structure your biologically, and then create an olecranon fossa in the back with burr. So in this study, we were able to review the outcome of 28 elbows, 50-50 for males and females, average age 47 years. And as you can expect, many patients had prior surgery. There were 3 elbows that had been operated already 6 times before we finally were able to fix them. Initially, the injuries were open 20% of the times, and 25% of the patients had an infection. And you can see 2 examples to your left of using a tricortical graft to make up a missing column, and then to your right using those 2 plates posteriorly so that the bone graft doesn't migrate anywhere else. And as usual, we check for pain, motion, scores, complications, reoperations, and x-rays. And what we found is that we would achieve union in almost every elbow, 92%. However, some patients had complications, including 2 joint collapse, 2 HO. And in our practice, in this group of elbows, the osteotomy healed 100% of the times. And this is an x-ray that shows that the technique, and you can see on the lateral x-ray how there is posterior iliac crest bone graft that is compressed with the screws across the non-union side. In terms of clinical results, patients improved in terms of motion, and as you can see, many patients were in a really poor score before surgery, and most of them improved to reasonable scores. Complications and reoperations, including 2 patients that required a total elbow arthroplasty. 5 patients had a contracture, and there was 1 deep infection. So even though the outcome in terms of healing, motion, and satisfaction is high, the reoperation rate is still high, secondary to either some joint collapse and also a number of patients that had a stiffness once the distal humerus had healed. So in conclusion, a stable fixation and a high union rate is possible in severe distal humerus non-unions using a technique that combines shortening, compression plating, and bone grafting. However, secondary procedures for release of contracture of total elbow are common, even though the non-unions do tend to heal. Thank you very much for your attention.
Thanks very much, Joaquim. Any questions from the audience for Joaquim on that paper? So I have a question for you, if you don't mind. For the non-unions, obviously, it seems to achieve good union rates in terms of its use in acute setting. How have you found that to be, or do you use it in the acute setting in patients who have a lot of comminution just above the articular component?
Yeah, so initially this was developed for non-unions, but to your point, when you have a patient that has substantial supracondylar comminution, you can shorten the humerus to some extent because contact and compression are your best friends. So I think if you want to sacrifice length to achieve those two goals, I think is useful. That's also useful in a patient with an open fracture because as the humerus gets shortened just a little bit, and I'm talking about maybe 1 centimeter, it will also decrease the tension on the soft tissue, so your closure is easier as well. But you have to remember, if you do that, you're going to eliminate the foci for flexion and extension. So you have to move the distal segment anteriorly and then make a new fossa posteriorly in the shaft with a high-speed burr.
Yeah. Another question?
Hey, hello. I mean, I'm just amazed about this technique, but I have a couple of questions. Do you rule out infection prior to do this, and how do you do it? And then the second one is, in the timeline, when do you consider to offer this to your patients? I mean, if a patient gets to your office and is being like in 2 years or so with this situation, would you offer this procedure, or would you reserve it only if it's been 8 months, 12 months since the first fracture?
Yeah, so those are very good questions. So in terms of the first question, can you repeat that again, the first one?
Yeah, how do you rule out infection?
So for infection, if the patient never had a known infection, I typically do an aspiration of the joint space and the non-union site, and then I always take cultures at the time of surgery. If a patient had a prior infection, I consider taking surgical biopsies through a small incision or arthroscopically. But I think it's important to rule out infection. And then in terms of time between the acute injury and your non-union surgery, we haven't really used a time limit. Of course, if it's 15 years, probably the chances of success are decreased. I pay more attention of what's the condition of the articulation, because there are some cases where you may be able to fix the bones and get them to heal, but if the joint surface is affected, they will have a poor outcome anyway. So for me, it's trying to tease out, is the joint still something I can salvage or not? And of course, age plays a major role. So if I have a patient that is 78, my threshold for arthroplasty is very, very low. If I have a patient that is 25 or 35, I'm going to really push it for fixation. That's why some patients have had surgery 6 times, and we went for the 7th.
I was about to ask you about that. If you consider this procedure, even if the patient referred to you after 3 or 4 attempts, would you consider doing that?
If the patient has enough bone stock, a decent articular surface, and is ultra young, yes. Okay. Oftentimes, what we found in those patients is that if you look at the first attempts, technically they were not properly done. So oftentimes the reason for failure wasn't that the patient didn't have enough biological support in their bones. It was more that the surgeon that did the operation didn't get it right the first time around.
And that's the last one. Did you notice any deficit of the triceps strength after doing this?
No, so there is one biomechanical study by Hugh that showed that if you shorten the humerus up to 2 centimeters, the strength of the triceps in extension decreases only by 20 or 30%. Realistically, these patients are happy if the elbow finally heals. Yeah. The problem is that many don't have adequate motion, so then you have to do a second surgery to get the motion back. So 5 of 28 had a contracture release.
Okay, thank you.
You're welcome.
We might maybe just do one other question, if that's okay, and then we'll move on to the next one.
Thank you for your presentation. I'll ask, if you cannot able to complete the reconstructed joint, if you have a small piece of missing, do you use iliac crest or allograft? Is there an age limit? So sometimes I use it in my practice. What's your opinion? Do you go to direct to arthroplasty?
Yeah, so if I am going to be doing a non-union, I typically will use iliac crest bone graft for those plates I showed. And if there is a segment of the joint missing, I will also use bone graft for that. But that bone doesn't have cartilage, so the key is to recess it a little bit so it doesn't articulate with the ulna. So just imagine you have a patient where the lateral column is present, the medial trochanter is present, but the center of the joint is gone. You could use a cylinder of iliac crest bone graft, but you don't place it collinear with the cartilage. You place it deeper so that it keeps the width, but it doesn't articulate. And that has been successful. You can use that also for allograft, but I haven't done it myself. I have done most of the times iliac crest bone graft.
Okay, thank you.
Okay, thanks.
Okay, we have to move on. Now we have Martin Eigenschink from Austria. He's talking about the lateral resurfacing of the elbow, a minimally invasive prosthetic treatment for radiocapitular arthritis, long-term results over 10 years.
Yeah, thank you for the opportunity to present our long-term results on the lateral resurfacing of the elbow in the radiocapitular osteoarthritis. I have nothing to declare. The isolated radiocapitular osteoarthritis isn't a common pathology, with its origin mostly post-traumatic, also primary and in some special cases with rheumatoid origin, and is a demanding condition, especially in the conservative, but also in the surgical treatment options, especially in young patients. Of the first line often are arthroscopic procedures, as arthrolysis in limitation in range of motion, and followed by salvage procedures as the interposition arthroplasty. As last line of defense, we have the total elbow arthroplasty with all its limitations. In our technique, we place the patient in UR in a lateral decubitus position. Posterior lateral approach or modified by a Morrey approach is performed to identify and visualize the radiocapitular joint. A special reaming and preparation process of the capitular surface and the radial head is performed, followed by sizing and stability testing, and then two-component press-fit implant is then inserted. In our study, we were able to include 40 patients, surgically treated by 2 experienced elbow surgeons. We included patients, active young patients with isolated radiocapitular arthrosis. We excluded all patients who had major arthrosis of the humeral ulnar part of the elbow joint and massive limitations. All patients underwent conservative and or surgical treatment prior. Preoperatively and at the predefined follow-up points, we evaluated with a questionnaire evaluating the Mayo Elbow Performance Index, ASSE score, clinical examination, also force testing, and x-rays for loosening. As I mentioned, we had 40 elbows, 50-50, with a mean age of 58.3 years and a follow-up of a mean of 14.3 years, a minimum of 10 years follow-up time. And we were able to create 3 subgroups on the origin of pathology. In these 40 cases, we were able to show improvement over all clinical scores, especially the pain scores and the ASSE and Mayo Performance Index. Nearly all patients were able to get back to their prior activity, and nearly 80% were satisfied with the result. All patients improved from the surgical procedure and would undergo the surgical procedure again. We also tested the range of motion. We were able to detect no major limitation of range of motion, stable over 10 to 15 years. And furthermore, we also tested the force compared to the non-surgical treated side, and we detected no significantly differences, but better results in the post-traumatic and the primary arthrosis group. We expected loosening due to the press-fit implant design, but we only had one revision, which was after 12 years with a wear of the polyethylene part of the prosthesis. To summarize, we were able to show in this study with all its limitations that we had a significant improvement, stable over 10 years with a low revision rate, no losing of implant parts, and only this one revision. So this technique and implant stays as a valid option in this small indication window of isolated radiocapillary osteoarthritis in young active patients, and the conversion to a total elbow arthroplasty stays under good conditions as a primary arthroplasty. Thanks for your attention.
Thank you very much. Very interesting. Are there any questions?
I have a question.
Okay.
So in the United States, the radial capitellar implant that had been on the market was removed from the market. So what is the maker of this? What's the company for this?
The company is the LRA Systems. There were a session 10 to 15 years ago. Then it was removed for 5 years. And we have the possibility in Europe, as I talk for Europe, about the last 3 years to do it again. So you can get it in the last 3 years.
Okay.
Again.
So it's a major advantage because, you know, heretofore it had been a very good implant and then was removed for other reasons. So nice paper.
Actually, it surprised me that you don't see any radial head loosening. It's because the radial head prostheses, they have a loosening in the long-term follow-up. And in your studies, actually, did you see any radial head loosening, especially around the stem, with or without clinical findings?
We haven't seen any loosening in our study case. But the limitation of the implant is that if you have high defects of the radial head, it isn't possible to perform this procedure.
Okay. So one more question, maybe.
Hi. In your studies, do you see any progression of the arthritis on the ulnar humeral site over the 13 years? Is there any radiological evidence that it slows it down, or it continues to progress?
We haven't seen any progression in the cases which had really only isolated radicapitular arthrosis. In these cases, with patients who had grade 1 to grade 2, there was a progression, but with no clinical relevance.
Okay.
Maybe just one quick comment. I don't know whether it's exactly the same implant as the Biomed implant that was used for a long time in Germany, and a city close to mine also it was used. And we saw quite a lot of cases with loosening of the radial shaft. And we saw also quite a lot of cases where the arthrosis developed over to the ulnar side. I think it should be common. I would expect it. I'm surprised you didn't see it 10 years. That's a long time. Mm-hmm. And everything is perfect. I don't know.
Yeah. I think we'll move on to the next presentation, if that's okay. So the next is by Ryan Bicknell, the comparison of triceps insertion violation during olecranon plate osteosynthesis using commonly applied olecranon plating systems.
Great, thanks a lot. Appreciate the opportunity to be here. I first attended this meeting a few years ago as an ASES exchange fellow, and it's nice to be back again after the pandemic the last couple of years. So this was conducted at Queen's University, where I practice in Kingston, Canada. So during fracture fixation, surgeons generally try to avoid compromising tendon insertions. However, in olecranon fixation, it's common practice to violate the triceps tendon insertion during plate fixation. If you look at the literature, there's really two studies by Keener and Barco looking at cadaveric studies measuring the triceps insertion. All of these utilize two-dimensional measurements using calipers and found similar findings to each other, but did not measure a significant portion of the measurements that we tried to do in this study. So the objective and hypothesis are firstly to quantify the degree of triceps insertion violation by commonly used olecranon plating systems. And our hypothesis was that a large portion of the triceps insertion is violated with most olecranon plates. Our primary outcome was to measure the surface area violated by these plates, and our secondary outcome was to compare two-dimensional with newer three-dimensional measurement techniques and to compare the two methods. So we had 12 elbows from 7 cadavers. Firstly, we removed the capsule from the triceps insertion. Then we isolated and exposed the triceps insertion, and then removed this and identified the triceps insertion on the olecranon. For the two-dimensional measurements, we did this similar to previous studies, so we used a digital caliper to measure the triceps insertion. on the olecranon. For our three-dimensional method, we used a light scanner to produce a 3D model of each elbow, and then from that 3D scan, we measured the triceps insertion itself. We then calculated the triceps, the percentage of the triceps violated by the olecranon plates, again, using both a two-dimensional and three-dimensional method. You can see on the right here that there's a portion of the olecranon that's not affected by the, or there's a portion of the olecranon triceps insertion on the olecranon that is violated by the plate, and then there's a portion of the olecranon that's affected by the plate but is not directly under the triceps insertion. So what did we find? The first graph on the left here shows the triceps insertion surface area for both the 2D and the 3D measurements. You can see the three-dimensional measurement was on average larger than the two-dimensional measurement. If we look at then on the right, the triceps, the percentage of the triceps insertion that was violated by both the 2D and the 3D measurement. Again, due to the differences in measurement techniques with the 3D measurement, this showed that on average a smaller percentage of the triceps insertion is violated when we measure with a three-dimensional method, but there was a large variation in both categories. This just shows the surface area that the surface area of the proximal portion of the olecranon plate for a variety of common olecranon plating systems, and the main point is that there's a very large variance in the surface area from about 133 to 280. If we look at the percentage of the triceps violation using both the 2D and the 3D methods. So in the first column is the two-dimensional method. If you compare the two-dimensional to the three-dimensional method, there is generally a significant difference with the percentage being smaller with the three-dimensional method. But there's a large variation. If you focus on the 3D method, it ranges from 39% up to 62%. So on average, about 48.8% of the triceps insertion is violated with common olecranon plating systems. However, there's a large variation. The Synthes wide plate has the most triceps violation at 62%. The Synthes extended plate and the right medical plate have the least triceps violation at around 39%. The triceps insertions are more oval in shape rather than square-like. Therefore, we recommend using this 3D dimensional or 3D scanning method, which we think has improved accuracy. The triceps insertion and olecranon surface areas had a percentage difference of about 28 and 13% when we compared the 2D to the 3D methods. This just shows our study in pink compared to Keener and Barco studies, and it's really fairly similar with a few variations. So in conclusion, the triceps insertion surface area varied between the 2D and the 3D methods, between 150 and 270 for the 2D and 170 and 360 for the 3D method. Most olecranon plating systems violate the triceps insertions, again between 50 and 80% for the 2D method and 39 and 62% for the 3D method. And we did find a significant difference between the two methods, and we recommend using the 3D methods due to the oval shape. What's the relevance of this? Well, currently the impact of triceps violation has not been really studied in the literature. We think a better understanding of the triceps insertion and the olecranon anatomy may lead to improvement in plate design, and should assess how the triceps. Next, we'd like to assess how the triceps violation correlates biomechanically and clinically with triceps dysfunction. Thanks a lot.
We have a question, yeah, go ahead.
Yeah, Dr. Bicknell, that was an excellent presentation, Dave Shukla. In your practice, or even just anecdotally, are you seeing a fair amount of postoperative triceps pain or insufficiency? And do we've been recommended to do things like you cut down in the middle of the triceps, repair it back over. Are you doing anything like that?
Yeah, I mean, that's the obvious question is how important is this? I think it's hard to know because these are often complex fracture. So everyone seems to have a bit of triceps dysfunction or triceps pain. It's my feeling that if we can violate that less, then patients have less pain. So I've moved from using a shorter, wider sort of proximal plate to a longer, narrower plate that we've shown in this study violates the triceps insertion less and gets into those other areas of the proximal ulna that don't have triceps insertion.
Okay. Another question at the back.
Definition of violation, please. I mean, do you release the tendon or do you just put a plate on top of it? What is a violation in your terms?
Sorry, can you repeat that question?
A triceps violation, what does that mean for you? Is that whether you put a plate on top of the triceps tendon or do you release it?
Yeah, it's a good question. So I think, there's two techniques. One is to split the triceps and place the plate underneath the triceps, and the other is to put it over the triceps. Either way, my feeling is that you're violating the triceps function, whether you're putting a plate over it or splitting through it. I prefer to put the plate over it if I can still get good fixation that way. But it does compromise the fixation you can achieve in some situations depending on the complexity of the fracture.
But in your study, did you just leave it, or how did you manage?
Well, in this study, we just looked at the anatomy, so we didn't.
Okay.
Yeah, we were just looking at the insertion. The next portion of this study is to do a biomechanical study to look at exactly that. So looking at different plating options or plating systems, and then either splitting the triceps and putting it underneath the triceps or putting it over the triceps, and then we're going to try to measure the triceps function biomechanically and potentially clinically would be a next step, but that's a little further down the road.
Okay, thanks very much. So we'll move on to the next one.
Yes. Morrey now from Mayo Clinic. Outcome of humeral allograft prosthetic composites with plate fixation and revision total elbow arthroplasty.
Thanks very much for allowing us to present our work. I have nothing to disclose. Everybody who does elbow replacement surgery knows that the two biggest problems are loosening and infection, and both of those problems can lead to significant bone loss, which have very few solutions for. In 2013, we published a paper on allograft prosthetic reconstruction for these difficult defects, and on the humeral side, utilizing circumferential coverage of the implant to engage the flange as our deciding factor on when to use an APC. And while we, in general, showed good results with these techniques, unfortunately, the humerus seems to be a bit of a weak side, and 2 out of the 6 humeri loosened. And we think that, in general, these were failures of the type 1 APC or the intussusception APC, and this was due to rotational instability due to the significant torque on the implants. In particular, how we use it. And this is easily understood when you think about the moment arm of insertion, just like a wrench. The larger the length of the lever arm, the more torque is applied. And certainly this is the case with these elbows when we use our hand out in space. And if we remove more and more bone, that lever arm increases and increases, and the torque at the insertion site of those APCs is certainly compromised. And this is true the more and more bone we lose, because you lose flange support, and you can only shorten so much. We heard from Dr. Sanchez that 2 centimeters of shortening will give you about 30% reduction in the strength. And this is also understood when you look at the polar moment of inertia, which reduces and resists rotatory loosening or twisting to the radius to the 4th power. So if the flange is engaged, you have an exponent to the 4th power. If the flange is not engaged, you lose all of that mechanical advantage, and we can see this in these megaprostheses that loosen with a twisting moment when they don't have flange or other means of resisting torsion. So the purpose of this study was really to look at what is the advantage of a plate when you're trying to join an allograft prosthetic composite to the host bone. And we looked at 41 revision total elbows and 5 different types fixed with compression plating across this host graft junction. and our outcomes in revision, reoperation, complications, and of course non-unions and failure of the hardware. So the 5 different types include a transverse cut, which is just that, a transverse cut across the host bone to join the allograft and the host with plate and screws. The second type is the same, but with the addition of a bone graft or other augmentation underneath the flange. The third is the intussusception, again, using a plate and screws. We remove the screws just for clarity to show what that looks like. The fourth is a bipolar step cuts, where the host has a step cut as well as the allograft, and then the addition of the flange support. And the last is a step cut on the allograft and a transverse cut on the host bone to allow for larger surface area contact. And this is an example of what that might look like intraoperatively. So at the final analysis, 68% of those elbows are surviving at the short midterm follow-up. 2 elbows had postoperative neurologic deficits, not unsurprising when you consider the revision nature. Most of these had multiple operations, and the dissection, as you can see in the picture on the right, is extensive. 1 elbow with delayed wound healing, and the overall reoperation and revision rates 34% and 32% respectively. So radiographs were available for 80% of those elbows, and non-unions happened about 36% of the time. 2 elbows had partial hardware failure, and 1 elbow had loosening away from the prosthetic composite on the humerus. So these are our Kaplan-Meier survival curves, and as you can see, we can do better. These are very difficult situations, so where do we go now? So options include using a humeral flange long enough to bypass the junction and gain fixation in the native bone when it's possible, support the anterior flange with bone and cement, or use strut-like extensions of the APC to increase the surface area. And all 3 of these go directly toward that polar moment of inertia and supporting the flange. So in general, we saw worse results with the transverse cuts across the host and the allograft, and a little bit better with support of the flange, but the best conditions really certainly improved the surface area contact with step cuts and longer surface area and of course flange support. So this is something that we've migrated to doing to ensure contact. That's 3D printed models and guides to ensure that there's a perfect junction. This was a failure of a prior APC, and here we used a femur for larger bone contact and surface area. It allows for a robust strut and a perfect junction with that type of planning. And here is the 2-year follow-up and healing of the junction. Here's a second example in the case of infection. So huge defects on both sides of the joint. Again, 3D planning to help with the cuts made intraoperatively and the surface preparation for the side-to-side apposition of the cortical strut extension. This is a 2-month postoperative, and this is a 3-year follow-up. I just saw him back in clinic, and fortunately, he's doing well, and his graft is healed. So the final 3 ways that we can maybe help is dual plate fixation to help with, again, the rotational stresses, looking at the biology or biologic augmentation, and finally, the potential for custom-made or modular or segmental tumor type of prosthesis to resist the stresses at the junctions. So in conclusion, salvage options exist for these very difficult cases with massive bone loss, but we do need to continue to research and innovate to develop reproducible solutions. Plates alone will not resist the torque across the allograft prosthetic junction, so other methods are needed. Thanks very much.
Thank you very much. Are there any questions? Yep. Frank Ulke.
Obviously, you have no problems to get allografts, isn't it, in your country?
No problem to get allografts in our country, no.
Yeah, because in Germany we have a very strict regulation, and I have used it widely for 2 decades, and now we are in a very difficult situation to get ones. So, and often argument what they say it is that you have, because you know there are old data from Mankin from, and let me tell you, 20 years ago about the resorption of allografts, and so what do you feel? What is really the long fate of allografts? Is there, if you have a composite allograft, Did you observe within the last, let me say, the first 10 or 20 years, any major resorption of the grafts? What is your experience with that?
That's a great question, and you're referring to Mankin's data on large bulk allografts, and there is a resorption. So it does happen. We don't know who it's going to happen in and when. And in our experience with the allograft prosthetic reconstructions, with the addition of cement, that perhaps eliminates or at least lessens the resorption over time, but it doesn't take it to zero, that's for sure. I guess the other question would be, what do you do what's your other option? So if you don't have the case of any choice of allograft, then you're left with the megaprosthesis, and I would just encourage you, if you're making the custom prosthesis, to ensure there's some form of rotational control for those. If you do have the opportunity to have allografts, that the junctions are perfect, because we do know that those will heal with creeping substitution, and if they don't resorb, now you've rebuilt the bone stock. So the long-term outcomes from that 2013 paper, we're looking up again to follow those patients from that cohort of patients, and as well as Pierre Monsat's earlier paper on the same topic, to look at things like the resorption rate and the overall failure rate. So great questions.
I think we might maybe move on, because we're a little bit behind on time, if that's okay. So the next paper is by Margo Dirckx and Jody Fadness from Brighton, acute and chronic coronoid reconstruction using the olecranon tip.
Great, thanks for letting me give this talk. So looking at coronoid reconstruction, we all know now the coronoid's important in elbow dislocation. It contributes to instability. And our understanding of coronoid has really changed over the years. We're no longer just looking at size. We're looking at that column theory of the elbow. We're looking at the actual anatomy, morphology of our coronoid fractures, specifically that anteromedial facet in the last couple of years. And we know with a deficient coronoid, that can lead to pain, that can lead to instability, and then osteoarthritis later over time. Specifically for PMRI, and we've looked at that last year, depending on the size, some of these do really well with conservative management, but for largest fractures, the advice is to fix. But what do you do when either there's a chronic case and a coronoid's deficient, bone's gone, or in an acute case and it's not reconstructible? So there's a few osteochondral grafts, of course, iliac crest, which is our bread and butter, but it's not very anatomical and isn't covered by cartilage. Some people use rib, very popular with our maxillofacial colleagues, again, taking a bit of rib out, not without risk, and it doesn't quite fit for what you need. So most commonly, I think people use radial head, because if it's fractured, it's there. Why not use it and plug it in front and use it as a graft? And that works fairly well, even though the fit's not perfect. But what do you do if the radial head's intact? You don't just want to take that out just to reconstruct your coronoid. And so that's where we were thinking about the olecranon tip. Interestingly, it's right there. You're doing your medial approach, you're looking straight at the olecranon tip, you go a bit more posterior. It is covered in cartilage, and there's been quite a bit of cadaveric work showing that that tip of the olecranon fits the shape of the native coronoid near perfectly, even more so if you use it from the contralateral side. You can take quite a large bit off without disrupting either elbow stability or extension strength, but it's important you do your osteotomy in the right plane. So don't go this way, don't go perpendicular to your dorsal ulnar crest, because you violate the triceps. However, if you go at about a 50-degree angle, you maximize the amount of cartilage you take off without disrupting the rest of the elbow. You plan that beforehand, how big your graft needs to be, and then you use that and either rotate it to reconstruct what you need for your coronoid. So that's what that looks like intraoperatively. We're looking here at the medial side. This was a patient with an anteromedial facet reconstruction. Even though that now seems obvious, there's only been really two cases out there. So this is the largest case series up to date. When this was published, there was only 4. We've done a few more now. They've all got a year follow-up. They're all PMRI, so they come to clinic. They have a positive varus grind. They have a positive posterolateral draw test. They have larger coronoid deficiencies. We address the LUCL at the same time. So for example, this guy, subacute, but if you look at the top right, very comminuted fracture, but too big to leave alone. So we took the bit of olecranon off, and he seemed to do quite well. We also see chronic cases. So this lady actually had an injury 9 years ago, treated conservatively, did fairly well, and then developed symptoms. She had a large non-union, and she actually opted to have her contralateral olecranon tip taken because we really wanted to reconstruct her anatomy, and again, had a good result. Subacute, 3 months down the line, similar story all over again. So here you can see this is the larger chunks taken from the elbow in the bottom middle. And she's now 2 years down the line, she's been discharged. It's not always perfect. One more case, again, chronic, 7 years ago. This guy, we're really happy with the end result, patting ourselves on the back on how good we were doing. One thing we failed to assess for was that this man liked taking a bath every day. Big guy, would push himself out of said bath, continue to do that post-op, and his LUCL failed, so we had to redo him with a synthetic graft, and he's got an ICS in at the time. From all these patients, they improved in terms of pain scores, they improved in terms of Oxford scores, and all our grafts united on post-op CT scan. So in summary, that olecranon tip is shown, it's safe to take. It gives you the best reliable restoration of anatomy compared to all the other osteochondral grafts out there. Your donor side morbidity is limited, especially if you stay on the same elbow, and you can use it both for acute and chronic. So for those of us who deal with coronoid deficiency, obviously, if the fracture radial head is there, you're going to use it anyway, use it. For those smaller fractures and you think you can get away with just doing the lateral side, absolutely. But when in need, think about using that olecranon tip. Thanks.
Any questions on that paper? Just I have a quick question for you. Just I noticed a few different types of fixation techniques that you used on the graft. Did you find that using the spring plates were more effective, less effective? Isolated screws, more effective, less effective?
So I don't think there's a very, I think that's more case dependent on the day. If it fits, you think, yeah, the plate fits quite nicely, snug, especially in the bigger grafts. For the smaller ones, then the 2 screws seem sufficient, that was fine. So I think if we take a bigger graft, the plate just feels a bit more satisfying.
Okay, and in terms of the approach, then were you using kind of a Hotchkiss over the top to get access to the front?
So Hotchkiss, and then when you're there, basically, your skin flap also, it has a tendency to fall backwards anyway, so you go a little bit more posterior, you skirt by triceps, and you're looking straight at olecranon, do a cut medial to lateral, and there it is.
Okay. Any other questions?
Yes, Dawood Maki from Watford, UK. Very interesting. Just one question. What do you do to the capsule? Because we know, for example, when I've done a few acute ones, the main thing is when you reattach the capsule, when you put an anchor and grab the capsule, you find that you've achieved stability immediately. So if you have somebody with instability and you put a bone block, pretty much similar to the shoulder, when you put large bone block, there's a chance of developing OA in the future. So if there is a residual instability and you've got just bony constraint there, what's the risk of OA, or have you had patients who developed OA? Because you're not doing anything to the capsule, right?
Right, so I think elbows and shoulders are fairly different there. So first of all, in terms of capsule, anterior capsule and elbow, we've got quite a bit of evidence out there that it can promote stiffness. So personally, it's not something that I'm a big fan of. And secondarily, when you're looking at the range of motion of your elbow, you're just reconstructing the coronoid. You're not necessarily adding extra bone, so it's a different anatomy to shoulders. Now, these guys, will they develop more OA? Possibly, but also related to their injury. This is 2-3 years down the line, so too soon to say. Of course, this is a ongoing issue, but I think if they develop osteoarthritis, it's because they've spent the last 9 years of their life living with an unstable elbow.
Okay.
Thank you very much.
Thanks very much.
May I?
Sorry, we have one more. Sorry.
Oh, right.
Yeah, just here. Congratulations for the paper. So just one question. Do you make any preoperative estimation of the size of the graft that you're going to need? Because the picture that you showed with the graft coming from the olecranon was a big piece of bone, and obviously that has some risks. So is there a limit in which you don't use this technique because of the size of the graft, and you evaluate that preoperatively?
So that's been checked biomechanically. 1 centimeter seems to be the cutoff for how far you can go. Now, we haven't had to push that limit so far, but as long as you do a 50-degree angle on your cut, you can get up to 1 centimeter without compromising stability of your elbow.
Thanks.
Okay, I think we'll move on then.
Thank you very much. So now we continue with Raphael Kohlprath, decision-making in displaced radial head fractures, patient or surgeon-based, an international survey. Coming a long way.
So, good morning, ladies and gentlemen. Thank you. I have the privilege to present one of the studies we performed during my fellowship by Professor Van Riet. Dr. Pierre Lemonnery couldn't come today, that's why I present this paper. The title is Decision-Making in Minimal Displaced Radial Head Fracture, an International Survey. That's a disclosure. Minimal displaced radial head fracture is nowadays usually treated by open reduction and internet fixation. But only a few of them, 0.1%, develop osteoarthritis secondary after 2 years. There's also a recent randomized control trial that shows similar functional results after 1 year, between operative or conservative treatment. The question is there a new trend for more conservative approaches for these fractures? The purpose of this study is to identify the factor influencing the surgeon decision-making in the management of minimally displaced radial head fractures. Hypotheses were that the decision-making is influenced by several independent factors related either to the patient or to the surgeon background. It was the only survey between May and August 2021. Top surgeons were asked around the world by email or social media by the senior author. There were 2 sets of questions. First, the surgeon-related one, and the second based on the 10 case scenarios. Point of interest were surgical versus conservative treatment. The second was duration of immobilization, and the third one was the time to return to normal activity. We asked the surgeon firstly the gender, the age, nationality, years of practice, number of radial head operated per years, subspecialty, for example, shoulder surgeon or elbow surgeon, for example, if there are any academic activity, some supervising of fellows of resident, type of radiographic classification used. We ask them to rank the fracture according several radiographic criteria, and finally, if they use or not CT scan for choosing the right management. Then for the cases, we give the surgeon the gender, the age, comorbidities of the patient, if they are manual walkers, or if they have any sports activities. We give also the full X-rays and also CT scan if they need it, and but we don't show them the number of fragment, location, displacement, surface of fracture, and ratio between the fracture and the radial head surface. Of the 186 surgeon contact by email, 57 response by email, and the rest by social media, which give us 101 surgeons around the world. Of them, 63% have chosen a surgical options. When we look for the multivariate analysis, we can identify 3 independent risk factors to choose for surgery. First, the nationality. Secondly, the subspecialty. And thirdly, the type of radiographic classification used. Here, the odd ratio, you see that an elbow surgeon have 77 times more chance to perform an operation for a Mason II fracture than the other surgeon. When you look at the patient-specific items, you see that manual walker, sports activity, and number of fragments seems to be the independent risk factor to perform surgical procedures. Here, again, the odd ratio, number of fragment give 17 times more chance to perform a surgery. Now, concerning the duration of immobilization, none of them were patient-related. Trauma surgeons have a slightly more chance to perform longer immobilization than other surgeons, especially elbow surgeons, which have shorter time of immobilization. When you look for the time to return to normal activity, here also no relation with patient items, but surgeon-related risk factors. For example, North Americans trend to have a longer period before return to normal activity, also not only professional, but also for sports activities. And to be an elbow surgeon, have to do the chance to be a little bit quicker to return to normal activity. Limitation of this study, 94% were male and 75% from Europe. It was only 10% from Asia and 10% from North America and 3% from South America. The second part is a survey, and as usual, it's a self-perception of own skills. So it's not, we cannot say if the surgeon is really have experience or not. For the discussion, there's a lot of heterogeneity, how to manage a radial head fracture. Independent risk factors to perform surgery are mainly demographic, dependent of the surgeon itself, and from the patient is manual workers, sports activity, or have a higher number of fragments. And for the immobilization and the delay to return to full activity, it's only from surgeon dependent. So thank you very much.
Thank you very much. Are there any questions? Otherwise, I'm sorry, because you took a little bit more time, so we have to continue.
Okay. So the next paper is given by Amura, mid to long-term results of a press-fit radial head arthroplasty, a comparative study between anatomical and bipolar implants in 97 consecutive patients.
Good morning, and thanks for the opportunity to be here presenting our study. Our study was made trying to focus on the mid-long-term result of radial head arthroplasty in press-fit implants. And we made a comparative study between two types of implants. First of all, if you search on literature for this radial head arthroplasty or press-fit radial arthroplasty, we'll find a lot of study that focused on low sample size and had only clinical results in the short to mid-term. Less is known in the mid to long term, and our study is about that part. The aim was to analyze and compare the clinical results and the causes of failure in the mid to long term in two different press-fit prostheses with short stem. We performed a retrospective study on a perspective database using a strict inclusion and exclusion criteria. The inclusion criteria were the use of two types of prostheses, a press-fit bipolar radial head and an anatomical radial head prosthesis. The indication were acute trauma and post-traumatic sequelae. There were only first implants, and the patients were in adult age. 97 patients were considered for the purpose of our study, and we divided it into two groups. The first group was made of 56 cases who received a bipolar conical stem, and the second group was of 41 cases who received a monopolar anatomical and with cylindrical stem implant. The mean follow-up was 6 years, and we had 26 implants that had a follow-up beyond 8 years. We then evaluate clinically the range of motion, and we use the most important scores for the elbow joint. Then we radiographically find any implant-related complications. Here are the results. First of all, we can see that the two groups were homogeneous for general characteristics, such as age of surgery, gender, follow-up, and preoperative diagnosis. Then we can see that all our patients, or most part of it, the satisfactory results with MEPI, and no statistical differences between the two groups were found in clinical results, except for mild differences in flexion and extension. We had 4 interventions for implant-related complication, 3 disassembly in group 1 due to a new trauma, and 1 revision due to the mobilization of the implant after 10 years. Here is an example of disassembly of radial head. Here is a female who received a bipolar prosthesis at 55 years old. We saw her after 10 years, and after the latest follow-up, he fell in the street and had disassembly of the radial head, as we can see from the X-rays, and during surgery images, we can see the wear of polyethylene head after 10 years, and that needed to be replaced. Here is an example of another woman who received anatomical prosthesis in 2008, and she's the one that had mobilization. And as we can see, in the first 3 years, we have a progression of the osteolysis that apparently stabilized after 3 years. After 9 years of follow-up, the patient was still asymptomatic, but had evident mobilization at fluoroscopy, and she needed a new implant, a revision of the implant with the longer stem. Radiographically, we have a high rate of stress shielding, and as we can see, the evolution that we found was higher in the first year and lower in between the first and the second year, and we evaluate the stress shielding until the latest follow-up. This phenomenon was similar in both implants, but was clinically irrelevant. Here is the case of a patient with the longest follow-up of our series. Here are the results after 2 weeks from surgery, and here are the results after 14 years. The patient regained all the range of motion, had no pain, and radiographically we don't see any implant-related complications. So the press-fit bipolar and anatomical radial head system had satisfactory clinical results and mid to long term. We have a very low rate of implant failure and mechanical complication. No clinical differences between the 2 implants were found, and we had a high prevalence of stress shielding in both implants. That was clinically irrelevant. However, longer follow-up is needed to define the causes of failure of this implant. Thanks for the attention.
So again, are there any questions? If not, we might just keep moving because we're a little bit behind. Yeah, I think we'll keep going. Thank you.
So we come to our last talk, biomechanical analysis of the humeral stem component of an elbow replacement, finite element analysis from Kuen Chin from London.
Hello, good morning. This is a work done at the University College London under the guidance of Dr. Taylor. I'm going to present on the behavior of the humeral component of elbow replacement during functional loading. As we see from Mark's talk, aseptic loosening is a major concern for elbow replacement. This is because of the complex anatomy and the complex kinematics of the elbow joints. So largely when we replace the elbow joint, we divide them into replacing the surface anatomy by reproducing the radiocapital anatomy, or we can simply replace it with a symmetrical sloppy hinge mechanisms, like the Discovery or the Morrey. These humeral implants then have to resist and react to the joint reaction force that's predicted to be several times of the body weight. Understanding the stress and strain profile in the elbow replacement will allow us to know how the implant will react, distribute the load, and displaced during functional loading. Now, we can study how the implant behaves by putting strain gauge on the stem of the implant. This is pretty easy. But what is important is to know how the end osteal bone reacts to the implant as well. This is technically very difficult to do because it is technically difficult to put a strain gauge on the intramedullary canal of the humerus. And therefore, a validated FEA model will be very useful in predicting the strain energy density and the one-meter stress around the implant. So as such, we developed a FEA model by taking a CT scan of a
60 years old full humerus lady with rheumatoid arthritis. This is then implanted into with a humeral component. We're using the Lima Discovery elbow replacement as a reference. This is implanted with assuming perfect bonding with the cement. The humerus is then stabilized with at the level of the proximal muscle girdle, i.e. setting the constraint at the level where the pec major, lat dorsi, and teres major inserts onto the humerus. We load this at 0, 60, and 90 degrees and look at various stem design criteria with different stem length, a different geometry of the stem. The stem is a curved stem with or without a flange, with a lateral shoulder offsets, at 3 degrees torsional offsets, and a 5 degrees valgus tilt, as well as a ventral 30 degrees forward tilts of the tines. And with this, we're able to look at the one meso stress and principal strain at the relevant level, i.e. the base, the mid-stem, the tip of the stem, and the anterior flange. And we will be able to study the SED at the end osteo bone at the corresponding level. So, in the laboratory study, as mentioned before, we take the stem, we attach strain gauge at the mid, base, and tip of the stem, as well as the anterior flange. These are attached with a tri-element 45 degrees rosette. This is then potted in a soft metal and loaded with a Zivic computer rig at 0, 30, and 60 degrees. We are unable to load this at 90 degrees like our FEA because of the constraint of the machine, so it's not big enough to put an implant at 90 degrees. Now, from this, we calculate the strain energy density from the recorded principal strain, which was then processed by the computer software. So the first thing is the FEA studies were consistent with the laboratory studies, but with a slightly different magnitude. As you can see from the table on the left, this is the data from the FEAs, and the data on the right of the tables are the data from the strain gauge studies. They show similar pattern of strain records, but slightly different magnitude. This is probably because of difference in the bone quality and also the mechanical strength of a saw bone. The strain gauge wiring has to be accommodated within the canal, and hence this has also given some imperfect cementation. But with this, we can use the FEA models to look at the end osteo bone at the cross-section area at different levels of the humerus. So we are presenting our results with a combined lab and FEA studies to make some sense of what does this imply to clinical practice. So as we see from the earlier study from Mark, that the implants move quite a lot when you don't have any support at the base level. And this is true because the strain energy density and the strains are maximum at the base of the stem. Increasing the stems to different lengths doesn't actually transfer the load very much to the tip. So most of the strain are concentrated at the base level. And this is illustrated by the blue bars on the graph on the left. Now, if we look at the condylar bone, in a normal stem, we don't see a lot of condylar bone loading. So you look at the color plots on the diagram on the right, you don't see a lot of changes in the color on the condylar bone. They're all blue colors. There's some very minimal changes. But as you put an implant with a internal flange, by that I mean beefing out the base of the stem like a latitude or a pre-chart implant where the base has an internal flange, then this will transfer some of the load onto the condylar bone. So, however, when you lose the condylar bone support, it results in significant displacement and increased strain at the base of the flange, like the bottom right of the diagram. As you can see, the flange now becomes very important to resist the displacement. So, the other interesting finding in this study is that we show that there was compressive strain, which is indicated by the negative number on this strain, so it's getting smaller, and a tensile strain at the back of the stem, i.e. it's getting longer. So it's when you are loaded with a physiological force, the implant actually doesn't just experience a compressive strain, but it's doing a bending torque at the base. The other finding that's relevant is that the principal strain is not parallel with the directions of the stem, i.e. meaning that there was a shear strain onto the implant, and this can cause micromotions between the bone cement interval.
Can you move forward onto your conclusion, if you don't mind? Thanks.
Yes. And so this can cause loosening. And so this is showing the displacement with bone loss. So this is the conclusion of my results. The 1 meso stress are highest at the base and the mid-stem. Longer stem doesn't confer any significant changes in the strain energy density. A condylar flange does help to distribute the load, and there was some shear strain responsible for micro-loosening. And finally, on the last slides, the strain at the level of the constraint, the Wurmeister stress comes very near to the yield stress, which can cause periprosthetic fracture. So in conclusion, these studies explain the clinical finding of to support the observation of condylar bone reabsorption, stress shielding, loosening, and propose a mechanism for failure of the elbow replacement. At the moment, we are having a PhD students to look at instrumented implant with telemetric, i.e. Bluetooth, measuring of the strain in vitro, and hopefully one day we can measure in vivo and know the actual joint reaction force. Thank you very much.
Thanks very much. I think unless there are any burning questions on the topic, we might maybe move on to the next session. Thanks very much.